Next, Anthony DeMaria is joined by Dr. Todd Brown, Assistant Professor of Medicine at the University of Alabama in Birmingham. They discuss optimal medical therapy goals for adults with coronary artery disease. Reason for geographic and racial differences in stroke, the REGARDS study.
As everyone recalls, the COURAGE trial compared optimal medical therapy to optimal medical therapy plus revascularization and showed that really was not a significant benefit of revascularization over optimal medical therapy. But the question has always been asked, how achievable is optimal medical therapy? And to address that question, Dr. Brown and colleagues conducted this study. So, Todd, can you just give me the background of your study, what you set about to do?
Thank you very much for this opportunity. We looked in an epidemiologic cohort called REGARDS, which is the Reasons for Geographic and Racial Differences in Stroke study. And this cohort was assembled between 2003 and 2007. And it is structured in such a way, the main thrust of the study is to look at stroke epidemiology, but obviously when you recruit individuals, and all the individuals recruited were over the age of 45, they're all at risk for cardiovascular events other than stroke as well. And so there's a lot of interest in doing work on coronary heart disease in this cohort. And these 30,000 individuals were recruited, interestingly, not like most studies where you recruit either from a hospital or from select individual areas like a county or a certain city within the United States. These individuals were recruited throughout the entire 48 contiguous United States. And so it gives us an opportunity to really get our sort of a real-world sample where we can look at how healthcare is delivered to these individuals. And what we do is look at the subset of people who at baseline in REGARDS had a history of coronary heart disease because the participants were asked if they had a history of myocardial infarction or revascularization. And if they answered yes to that, then they were considered to have coronary heart disease at baseline. And in that sample, we looked at simply what their risk factor control was at the time of enrollment, which, like I said, was between 2003 and 2007. And we focused on some of the key things that were identified in the COURAGE trial, such as use of aspirin, blood pressure control, lipid management, glucose, smoking status, weight, and physical activity.
So this is self-reported coronary disease, but I assume reasonably accurate.
Right. So the participants were asked if they were ever told they had a heart attack and if they had ever had some type of revascularization procedure, either bypass surgery or percutaneous revascularization. And these questions that are asked are commonly asked questions in epidemiologic studies such as ARIC and CHS, and have been validated in other settings to be, reasonably accurate at identifying individuals with coronary heart disease.
Now, as I recall, the 7 criteria for optimal medical therapy in COURAGE were perhaps a bit stricter than many people consider. For instance, what they were looking for was a systolic blood pressure of less than 130 millimeters of mercury. My understanding is you did use the COURAGE criteria for control of the 7 risk factors.
Right. So we tried to base this as much as possible on what was done in COURAGE. We can't duplicate entirely everything. For instance, we didn't have access to hemoglobin A1C values, so we had to use glucose values as a proxy of that. But we had a lot of discussion about which targets we wanted to choose. And there was a lot of debate amongst the co-authors about exactly what numbers to pick. And what we ultimately decided was that in COURAGE, since we had a randomized controlled trial, that they attempted to achieve these. Now, admittedly, they didn't achieve it in everyone, but there was at least an attempt to achieve these. And it appeared that when you tried to achieve these risk factor targets, that it was successful and that people did well and did well without revascularization. So the idea that we had was we were going to pick the numbers they picked. This was studied in a randomized controlled trial. And the idea was how well is risk factor achievement done in the community based on the numbers that were selected in COURAGE. And so we had to pick something, and so we thought it would be of interest to choose as much as possible to adhere to what was done in COURAGE.
Yeah, I understand that's perfectly reasonable. It's just, for instance, the BMI criteria was less than 25 kilograms per meter square, which is probably a more stringent criteria than most physicians are using in their office.
Sure. The other thing we did to try to get at this was to do a subset of the risk factor targets where we only looked at aspirin use, the blood pressure target, and LDL cholesterol control, which Encourage is actually not as aggressive as what we currently would think about LDL cholesterol goal because it was less than 85 milligrams per deciliter. And so we looked at just those three in a separate analysis as well to sort of get around the fact that physical activity, BMI, glucose control, some of the other factors are more difficult to achieve. And so looking just at the subset, though, we saw similar findings.
What were your results? What percentage of patients, for instance, were at target for all 7 risk factors?
For all 7, it was very few. There were less than 1% of people that actually met all 7. The average number was about 3.6 of the categories were met. And the sub-analysis of just the aspirin use, blood pressure control, and LDL cholesterol less than 85, it was only 16% that reached all 3 of those targets.
Only 16%. Now, were you able to tell whether it was the patient that had discontinued therapy or the fact that the therapy had never been prescribed?
That we can't tell. All we know, we're just simply looking at what the risk factor level was. So we don't know, for instance, obviously if the person wasn't taking aspirin, it could be that they just didn't take it due to non-adherence, et cetera, where they were not adherent with their lipid or blood pressure medicines. All we can really do is tell yes or no whether or not their risk factor target is met or not met.
What did you conclude from these findings?
I think our conclusions are that risk factor attainment overall is low. And there's a lot of reasons for that, as you alluded to. Some of this could be non-adherence with therapy. Some of this could be, for instance, we don't take into account what the LDL cholesterol was before. Maybe their LDL cholesterol was 250, and the fact that it was above 85 may have been 86. And so, they still had significant reduction in LDL cholesterol. So this is only a one-time snapshot at things like blood pressure and cholesterol. We may have caught them on a day when their blood pressure was high or their cholesterol might have been reduced significantly from baseline. We really can't tell those things. So there are some limitations. But overall, the number of people who were at high level of risk factor control was low. And that's related to a lot of things. It may be related to patient adherence. It may be related to side effects of medications or intolerances. But nonetheless, it's lower than what was achieved in Courage as an example. And so there seems to be room for improvement. Never going to be 100%, but it does seem that we could probably be doing a little bit better than what we're doing.
As you point out, it's hard to know why exactly such a small percentage of patients, 16% of patients having their blood pressure and lipids controlled and on aspirin, that's really, to me, shocking, and we really don't know why that is. But what are the implications for the Courage trial? One of the issues that's been raised since the report of the Courage trial was that the medical regimen followed really was not likely to be achievable by the majority of patients in general cardiology practice. How do you interpret your data in light of that?
I agree. I think there are going to be some patients who are not going to be able to achieve all these targets, particularly when you talk about BMI being less than 25. That obviously will be quite difficult for many people. But I think there's probably some number between 16% that's bigger than 16 but less than 100% of people that can have blood pressure controlled, LDL cholesterol less than 85, and be on an aspirin. So I think that although it is true that not everyone can achieve these targets, I think we would all agree that more people can achieve these targets than what we're currently observing. And importantly, one of the other things that we did was look at vulnerable subgroups. And so, for instance, women and African Americans were less likely to achieve these targets, and individuals with lower incomes. And so I think that we do identify subpopulations that are particularly more vulnerable to not achieving these targets that probably deserve increased attention at risk factor modification.
Yeah, no question about it, but you kind of wonder, even if you doubled or tripled the 16% rate of aspirin, lipids, and blood pressure, that it still would be relatively low relative to what Courage applied in optimal medical therapy. Nevertheless, an important message to all of us that at the current time, we really have some opportunities for improvement in reducing risk factors in patients who already have coronary artery disease. Thanks very much for sharing this with us.
Thank you.